Next session is by Dr. MARIAN, PAULY, Senior Consultant and Head of the Department Orbit and Oculoplasty, Giridhara Institute, Kochi. She is a very humble human being and a prolific surgeon, one of the best in her field. I welcome her for sharing her experience in the management of lid and lacrimal surgeries.
Good evening. Thank you so much, Dr. Sindhu and team, for giving me this opportunity. In 7 minutes, I'll just try to finish this lid and lacrimal injuries. So, lid and lacrimal injuries, not a acute emergency, but optimum to repair within 24 hours. So, there are some few principles. One, reapproximate the tissues as accurately as possible, close with the minimum tension, obliterate the dead space. If there is dead space, blood can collect, it can cause infection as well as the wound can reopen. Then layered repair is always preferred because it gives a very good scar, then good lighting and hemostasis. So first, when we see, always explore the wound. Even if you think the wound is very small, always explore the wound. Sometimes what we can do is, it is very painful. We can give little local infiltration and explore the wound for foreign bodies mainly. Then copious irrigation, removal of any dust particles. Then determine the depth and check the alignment of tissues to see any tissue loss is there or not. So after alignment, so in this, if you see, there it looks like there is a tissue loss, but when you realign, there is actually no tissue loss. So he did well. So coming to superficial and deep laceration not involving the margin, simple closure or layered closure depending on the depth of the wound. We can use 6-0 vicryl for orbicularis and silk, nylon or plain gut for skin. Then interrupted or running suture, always try to evert the skin edges. The thing is, if you evert the skin edges, you will get a good scar, because the scar will always go for contraction, fibrosis and goes depression. If you don't evert, you can get a depressed scar. And main thing is, should not close the septum. Undermine the edges if there is difficulty in closure. That means if the wound is under tension, and suture removal in 5 to 7 days. So coming to lid margin, first before I go to the lid video, so try to understand the anatomy of the lid margin. There's a posterior edge, then meibomian gland orifices, then gray line, then lash line. So basically, meibomian gland orifices, gray line and lash line, we have to keep in mind for the margin tear repair. So first, there's a triple suture technique. First is meibomian gland orifice, gray line, then lash line. So this is a small video. Under local infiltration, this is a full thickness lid tear. Go through the meibomian gland orifice, far near. So once it is come out, have to go through the orifice. Otherwise, there is irregularity in the lid margin, which later can lead to all the problems sometimes. So what I do is 2 glands away and then 1 gland come out through the nearest gland. So this is actually the cardinal suture. If this suture is correct, then you are all right. So once the lid margin is stabilized, then suture the tarsus with absorbable suture. We can use 6-0 vicryl, and make sure it should not go full thickness. If it goes full thickness, it can rub on the cornea and causing all the corneal problems. You can take 2 or 3 sutures in the tarsus. So once it is done, then suture the orbicularis. So what I do is, I try to put inverted sutures. That means the knot goes posterior. And it gives a very good approximation of the skin. See, the skin is approximated. So complete the orbicularis suture. Then go to the lid margin. So now in the lid margin, we have taken only 1 suture, and then I kept it loose, so tighten it. Then take the next suture. I take 1 suture anterior and 1 suture posterior. This is the posterior suture. It gives a very good alignment of the posterior lid margin. So now this suture has to be it should come to the meibomian gland orifice suture, so that the suture tip will be anterior and it will not rub the cornea. So then now go to the lash line. So once the lash line suture is done, keep all the sutures in the anterior part. Then finally, so you can see the eversion of the edge. Then complete the suturing by closing the skin with non-absorbable and put the other lid margin sutures into that skin suture, so that none of the sutures will irritate the cornea. This is the final end of the repair. In pediatrics, use absorbable sutures and tag the long end of the suture to the lid skin so that it will not irritate the surface. This is the lid tear run 2 weeks post-op. Again, there are sometimes multiple fractures, then suture everything separate. So coming to the repair of the canaliculus, here the main challenge is to identify the distal end of the canaliculus. It's very easy, to be frank, under microscope. First dilate the punctum. I use mini monoca, it's a monocanalicular stent. So now how to identify the distal end. So now you can see in this, so the fibers of the orbicula is done like in a circular fashion. In the middle of that you can see a uniform surface with the pale pink. So that's the distal end of the canaliculus, and then put the tube and do the pericanalicular suture with the 70 vehicle and then close the wound as per the lid tear repair. Coming to levator injury, suspect when you see fat in the wound. And how to identify the levator? Ask the patient to look up and down so that the levator will move along with the movement. So once the levator is identified, suture it with 60 vicryl and then complete the lid as per the lid. So this is levator injury, you can see, and after repair there is a total ptosis. It has improved, and after 6 months we did a levator resection. Coming to eyelid avulsion, sometimes you can get the total loss of lid. If possible, try to retrieve the lid from the injured site and resuture it. Otherwise, you have to go for lid reconstruction methods. Medial canthus, you can get associated along with the canalicular injury. So you have to fix the canthus to the medial canthal tendon. It'll take only 1 minute. So coming to complications, you can get lid notch. If not sutured properly, you have to revise with wedge resection. So this is the problem. If you incorporate septum in the wound, you can get lag of thalamus. This has to be revised immediately within next day or within 2 days. Misalignment of tissues, can get sometimes. You have to realign the tissues and then suture it. Lateral canthus also have to be very careful. You have to attach the canthal tendon to the lateral canthus. Otherwise, you can get ectropion and other problems. So to summarize, you can get an excellent outcome if you do a very meticulous surgical technique. Thank you.
Thank you, madam, for the informative talk. The next